Hello and namaste to all of you. This is Name-Shalu Singh from Department of Physiotherapy and Diagnostics from Jayoti Vidyapeeth Women's University. So for today's topic, I'll be discussing with you about ascitic fluid. So ascitic fluid is basically the fluid which accumulates in your peritoneal cavity, and the disease condition or the abnormal condition in which the accumulation of ascitic fluid takes place is known as ascites. So many diseases they can cause ascites, but the more common causes your portal hypertension, which is usually due to liver cirrhosis. And ascites, it does not typically become clinically detectable until there are at least 500 ml of fluid present. So if a large amount of fluid accumulates, the abdomen can become very distended and tense, causing the patient to feel short of breath due to diaphragmatic splinting. An analysis of ascitic fluid can help determine the underlying cause and identifying the signs of infection. Now, a sample of fluid is typically obtained using needle and syringe, so which is known as ascitic tap or paracentesis, which will be sent for the analysis. Now, there are various clinical features which signify ascites. One of the most important is your abdominal distension. Second can be your abdominal discomfort. Third, weight gain. There can be shortness of breath or the reduced appetite. Now, the appearances of ascitic fluid. The appearance of such ascitic fluid can be useful in narrowing the differential diagnosis. So, the table uh, will define the appearance of ascitic fluid varies depending on the underlying etiology. So, if the fluid looks like clear or straw colored, it you can interpret or the condition can be liver cirrhosis. If it ascitic fluid looks like cloudy, so it can be the case of bacterial peritonitis, perforated bowel, or it can be the case of pancreatitis. If ascitic fluid appears to be bloody, then it can be the case of malignancy, hemorrhagic pancreatitis, which is often accompanied by Gray Turner's sign. Now, if ascitic fluid appears to be chylous or milk colored, then it can be the case of lymphoma, tuberculosis, or malignancy. Now, the biochemistry behind ascitic fluid. So, if you are about to biochemically analyze the ascitic fluid, so it will provide you with useful insights which can help narrow down the differential diagnosis. So, the typical patterns of biochemical findings are associated with specific underlying disease processes. If you analyze for protein, so the normal protein levels in ascitic fluid are from zero point 0.3 to 4.0 grams per dl, and more than 4 grams per dl in case of a systolic blood pressure or TB. Now, if you test your ascitic fluid for glucose, so it will be similar to your serum levels. So in normal cases, the levels are similar to your serum levels, and in case of TB or in case of malignancy, the it levels are less than your serum levels. In case of if you are testing for amylase, then normal levels are similar to your serum levels, and in case of pancreatitis, it is more than your serum levels. Now, under upon microscopic examination, so the microscopic examination will provide valuable information about the number and type of red and white blood cells within fluid, which can help narrow down the differential diagnosis. So, red cell count. So, will in normal conditions, there are no red blood cells. In case of malignancy or tuberculosis, you'll find more than 100 per microliters of red blood cells. In case of hemorrhage or trauma, there are more than 100,000 microliters of red blood cells. And if you're looking for white blood cells, so less than 250 per microliters of normal or white blood cells can be seen. And again, in case of cirrhosis, less than 250 per microliters of white blood cells will be seen. So in abnormal conditions, the amount of white blood cells will be increased from 250 per microliters. So if it is more than 250 per microliters and then more amount of neutrophils are present, then there will be systolic blood pressure. So if more than 250 per microliter, then and predominantly more lymphocytes are there, then it can be the case of TB. Now, what is a serum ascitic albumin gradient, which is SAAG? So SAAG is indirectly measured by portal pressure, and it can be used to determine if ascites is due to portal hypertension. So SAAG can be calculated as a difference between your serum albumin and ascitic fluid albumin. So, how will you interpret the results now? The high SSAG levels, that is more than 1.1 grams per DL, will suggest that ascitic fluid is transudate. And if it is SAAG levels are less than 1.1 grams per DL, then it will suggest that ascitic fluid is exudate. So there are various causes of high and low your low serum ascitic albumin gradient. So if there is high serum ascitic albumin gradient, that is in case of your transudate, it suggests the presence of portal hypertension, which may be caused by cirrhosis, hepatic failure, venous occlusions, or Budd-Chiari syndrome, and fulminant hepatic failure, alcoholic hepatitis, kwashiorkor, malnutrition, and the causes of low serum ascitic albumin gradient can be your malignancy, infection, pancreatitis, and nephrotic syndrome. So you can also find, or you can also diagnose for lactate dehydrogenase in your ascitic fluid. So it is one of the other ways to differentiate between exudate and transudate. And if LDH levels are less than 225 units per liter, then this is the case for your transudate. And if LDH levels are measured more than 225 units per liter, then this is the case for exudate. And these methods are largely replaced by the use of serum ascitic albumin gradient. Now, there are various causes, other causes for serum ascites albumin gradient, which can be a cirrhosis, heart failure, hepatic venous occlusion, constructive pericarditis, and your Kwashiorkor. Now, some rare causes can be your Meigs syndrome, vasculitis, hypothyroidism, renal dialysis, peritoneum mesothelioma, and abdominal tuberculosis, and mastocytosis. So, in case of ascites, so it shows a various amount of pathophysiology. So pathophysiology in ascitic fluid, it can accumulate as transudate or exudate, and up to 35 liters are possible. So roughly transudates are result of increased pressure in hepatic portal vein, which is more than 8 mmHg, and usually 20 mmHg, so which is due to cirrhosis. While exudates are actively secreted fluid due to inflammation or malignancy. So as a result, high in protein, lactate dehydrogenase, and a low pH, which is less than 7.30, and a low glucose level, and more white blood cells. So transudate have more low protein, less than 30 grams per DL, low LDH, high pH, normal glucose, and fewer than 1 white cells per 1000 millimeter cube. So, clinically, the most useful measure is the difference between ascitic and serum albumin concentration, and a difference of less than 1 gram per dl, that is 10, it will imply an exudate. Now, a portal hypertension plays an important role in production of ascites by raising capillary hydrostatic pressure within splenic bed, and regardless of the cause, sequestration of white fluid within the abdomen leads to additional fluid retention and by kidneys due to stimulatory effect of blood pressure, hormones, and notably aldosterone and sympathetic nervous system, which is also activated, and the renin production is increased due to decreased perfusion of kidneys, and an extreme disruptions of renal blood flow can lead to hepatorenal syndrome. And other complications of ascites includes spontaneous bacterial uh, uh, peritonitis due to decreased antibacterial factors in ascitic fluid, such as complements. Now, this was all about ascitic fluid.